That is always provided to you for CMEs. I do not have anything to disclose, no financial arrangements related to the content of this activity. We're going to be talking about substance use disorder, specifically how to assess and screen. And I'm going to be going over some public domain instruments, as well as some that are for purchase. We really want to introduce sort of foundational models of how you would screen and assess substance use disorders and co-occurring psychiatric illnesses, as well as introduce some of the tools. So there's a lot of slides to fit into 30 minutes. There's a lot of content here. I know Rana is going to be sending these to you all afterwards. So I'll move through the detail fairly quickly. And so that way if we have time for discussion or anything at the end, but you will get all of this detail when you receive the slides. So to start off, before we get into specific models of screening, it's helpful to kind of embed this in what really is going on in the community. And so here's some statistics that tell us that, at any given time is a large percentage of Americans, about 136 million, 52% can report heavy drinking or using alcohol, and then 6% of them report heavy drinking. 9% report illicit drug use. So it's a fair amount of folks that might cross your path, regardless of what role you're in. Obviously, those of us that work in specialty centers, we see much higher rates, such as these numbers, right? The ones that are actually going to go on to need treatment, that 8% to 9%. And we know what's recommended for this population is that if they're going to receive specialty treatment, that they really should have both their substance use disorder and their mental health issue treated at the same time. Unfortunately, those that need that type of treatment don't always make it to those locations. There's a real lack of available specialty services across the country, and definitely here in the state of New Mexico. It can be costly to have numerous substance use specialty services available. And there is still a heavy stigma to treating this population of patients. And so what does that do? That opens up really, I think, opportunity and need to have people that are working in primary care or general practice areas, community mental health areas, have the ability to screen for and start to work with this population of patients. So I think that's one of the reasons why most of you come to this ECHO series, is so that you can get some of this specialty information to help assess for patients with these conditions, and also even be able to treat those that have some of the mild to moderate severity of substance use disorder. So that's where screening and assessment plays a really, really important role, because it's one of the things that we can do to start to track or catch patients and then track how they're doing along the way. So I think it's important, before we talk about what's best practice now, to look at how we've interacted with these patients historically. So historically, patients would interact with the treatment system, whether that was in a specialty care location or general practice location, only at points of relapse or accelerated symptoms. So they're only engaging with treatment providers when they're really struggling. And this gets into sort of a crisis engagement pattern. And so that's that complication-driven practice. Or they're being sent to specific treatments based on diagnosis and not based on necessarily the full parameter of variables that need to be treated to help somebody establish recovery. So what we recommend, instead of that kind of, they engage with us when they're really struggling and then discharge with us as soon as those symptoms get a little bit better, think about treating substance use disorder patients from a chronic care management perspective, which really means that we're looking at providing a continuum of care that includes not just their substance use issues, but the full biopsychosocial spectrum. So all of the dimensions that need to be addressed so that somebody can have true long-lasting recovery. So what does that look like, this development of a continuum of care? Well, it means understanding that folks with substance use disorder are going to need options as part of their care plan to step up or step down. So they could step up to a higher level of care, such as IOP or residential, and then be able to transition to outpatient. And then from outpatient, be able to transition to community supports, 12-step programs, other peer-based programs for long-term maintenance. So as a provider, if you think about that patient moving up and down that continuum of care, every time they're in one established care setting, you could label that as an episode of care. And so thinking about breaking up the work that you do into these discrete episodes, and at the beginning and the end of each one of those episodes is a time point for assessment and treatment planning. And what does that allow us to do? That allows us to keep patients engaged, to catch things before they get really bad, and possibly to catch things before they drop out of care. Another thing that's really helpful in thinking about screening, especially in general specialty areas, or general health areas, sorry, is if you screen everybody, then you can catch those that may not self-refer to specialty substance use disorder treatment, such as this is showing that the vast majority of people that you're going to screen, they're coming in for medical reasons, not non-substance use related reasons. They're not going to be positive on that screener, and so it's just a matter of kind of maintenance. We check on it periodically, but a percentage are going to fall into that harmful or dependent category, and we're going to want to catch those folks as soon as possible and get them intervention, or get them connected to that continuum of care. One of the models, I'm going to introduce two different models that can be used to start this screening and assessment process, comes from the American Society of Addiction Medicine, or called ASAM. This is an ASAM state here in New Mexico, so we're actually encouraged to use ASAM criteria for how we assess and diagnose. And this is, I think, a nice rubric to understand what is ASAM placement criteria. So this model is one of the things that encourages universal screening, so everybody should get screened. From that screening comes an assessment process, which allows us to diagnose a substance use disorder, the severity of that condition, and then look at all of these different placement dimensions that will inform a decision rule in terms of what level of care is going to be best for a patient. And so on that continuum, we need to know where to place. We can't make arbitrary or subjective recommendations, or we're probably not going to have very good outcomes. So using a model like ASAM can help us both in catching those folks that may be starting to enter into the risky phase before they really get to harmful or dependent. And if we do catch them, what level of care would be most recommended? Would it be best to keep them engaged with us at our level of care? Do they need higher? Do they need lower? And then using that same model on an ongoing basis as we treat patients to inform if a change is going to be necessary. These next two slides show some studies that are really helpful for saying, why is it important that we use something like ASAM? Because we can have really poor outcomes in terms of retention rates, in terms of engagement in care, which we know has a huge impact in long-term prognosis for folks. It's much poorer when we don't have good retention and retainment in care with our patients. So if we're under matching, we are going to have those worse outcomes, kind of regardless of substance. So that means we really need to use some kind of a model that allows us to use evidence to inform that treatment recommendation. So we can say, would it be best for them to go to X level of care based on this particular assessment or screener? And here's another one that shows a dropout rate related to that under matching piece. So we have much better outcomes if we can match appropriately. So using something like the ASAM model can be very helpful for that reason. It's highly reliable and feasible. It's a really great model if you haven't received training in it already to help inform those outcomes. Another model that endorses universal screening, and a recommended sort of step-by-step process is the Aspert model. That stands for screening, brief intervention, referral to treatment. This model has been disseminated in emergency rooms or in urgent care settings with some fairly good success, which says that if we can assess everybody, we can catch those higher risk patients sooner and then do a series of steps with them that is evidence informed, similar to the Asean model. So the steps that are included with Aspert is once you screen someone and they're positive on that screener, you provide them feedback in the moment about those results. You have a brief coaching discussion with them where you talk about their what they like, what they don't like about their use, what they consider changing it. You make some respectful recommendations for what they could do to increase their health and safety in terms of their use of that substance. Maybe even encourage a specific skill or teach a specific skill, and then determine what method of follow-up is going to be best. So based on how they've screened and how that interaction goes, will determine if you're going to follow up with them or if, again, you're going to make a recommendation to a higher level of care. We've given you a link to an app, an Aspert app that you can actually download this entire package from. So this is a visual explaining that process. So everybody gets screened. And if you're not seeing folks frequently, as in seeing them weekly for some reason, then you probably want to screen at every single encounter. And ideally, the majority are going to fall into that low risk category, and you just carry on with that appointment. Now, if they fall into a moderate risk category, you're going to do that brief intervention list that was on the previous slide. You can have that brief conversation and a little bit of coaching to help them restructure their behavior, because sometimes it really is just a lack of having a conversation about it, or a lack of awareness or knowledge. What is the right amount to drink, or what is too much of a risk related to their use. If they're falling in the moderate to high risk, then you're probably going to need to have some follow-up that's going to include some higher level interventions like brief motivational interviewing or motivational enhancement. And then if they're following the severe category, then most likely that's going to recommend a referral to some sort of specialty treatment like the ASAP program or like a substance use disorder program of some kind. So now that you have this idea of these kind of big picture models, how would we go about applying them in terms of screening? So with screening, what we're wanting to do again is just pick up with everybody any unhealthy alcohol or drug use that could lead to negative health consequences. And our screens need to be pretty broad, very simple to use, and help us with that match to treatment, because if we match appropriately, we're going to have improved prognosis. Screening should occur right after seeking services or as part of that entry door, right? If that's an intake appointment, screening is part of it. And if you don't see your patients very regularly, they just come in sort of as needed, then screening should occur at every single encounter. It can be used to not just help to filter risk related to substance use disorder, but it can also be used to filter risk related to other mental health conditions, such as depression or anxiety, suicide. These are all common things that we want to routinely be screening for. And it can be used in a variety of settings. Again, these tend to be self-report, very brief, easy to use, so the results can be shared in that moment. You can also use some screeners to track symptoms over time. So once you've started working with somebody, you've identified, oh, they are drinking at a higher risk level. So I'm going to use a screen with them every time they come in, specifically targeting their alcohol use so that we can track that over time to see if it's improving or getting worse. And then again, screeners can help to identify that should I make a recommendation to a higher level of care or lower level of care than the one that I'm currently providing. Now, that's different than assessment. Assessments are much more complicated, and those occur after someone's been screened. So if they're screening positive, so give everybody the screen, then only the percentage of patients that screen positive are going to get that more intensive assessment. And so that's typically collecting a whole range of data to be able to inform a diagnosis and treatment plan. And it's going to include information about mental health and substance use disorders and how they are kind of interacting with each other It may also include things about their readiness for change or the stage of change that they're in, their kind of motivational ruler where they may be, and then strengths that they're bringing to the table, strengths or skills that they may already possess that could be capitalized as part of that treatment plan. So screeners, let's start there before we go into assessments. I've provided you the public domain ones. So these ones are, you don't have to pay anything for, they've been widely used for a long time. And I wanted to just go through and show you each one of these tools so you have a sense of what they are and how you could use them and how they could line up both for kind of catching risk and also for making some treatment decisions. So the CAGE is a relatively older assessment. It's used for alcohol in men or women. It's just 4 questions, and it can help inform lifetime issues with alcohol use disorder. It has this nice graphic on it, which can be part of that teaching back coaching piece of the Aspert model, where you're educating people about amounts of alcohol for a standard drink. So you can have a conversation how much someone might be drinking. And it has different recommendations for men and women, which aligns with our current health recommendations. So this is the CAGE, and it stands for cut, annoyed, guilty, and eye opener. That's where the CAGE is coming from. It's a yes, no, and so you just get a total score, which relates to if they're in that high risk or low risk category. Now, the Audit C came along. It was developed by the WHO from information taken from the CAGE. It's structured similarly in that it has different scores for men and women, and it has a brief version, the Audit C, and then the full version, which is just the audit, which has all 10 questions. And it gives you a little more data in that it's not just yes or no, but it's asking frequency or duration and giving you a little bit more information in terms of the quantity and intensity of drinking that someone might be engaged in. Now, the main difference between the C and the regular audit, you can see that if part of your process would be to just administer the first 3 questions is the Audit C. And if they're negative on all of those, then you don't need to administer the rest of the screener. Or if they're positive and you'd like more information, then you could administer the rest of the screener and get a little bit more data to support that coaching conversation or making some decisions as to are they going to need a possible referral to specialty care. The DAST is another public domain instrument that's widely used. It stands for Drug Abuse Screening Test. And even though it's in a yes or no format in terms of responses, the questions that the DAST asks is slightly different than some of the other questions, which are focused on the substance itself. DAST is focusing on the consequences of use. So this could be applied to any kind of drug, alcohol or illicit drugs, or a combination, because it's looking at the functional impairment related to that drug use. There is an adult and an adolescent version. And the nice thing about the DAST is it does align with ASAM criteria. So what does that mean? It means that when you score the DAST and you go to the scoring page, it tells you the range in which that score falls, if the patient is appropriate for outpatient care, or if they would be better served by intensive outpatient, or if maybe they would be better served by residential. So it helps with that matching discussion if you're using ASAM or a model where you're really wanting to have clear evidence that helps to match those treatment recommendations. The INM Assist is similar to the DAST in that way, in that it also lines up with ASAM criteria. It stands for NIDA Modified Alcohol, Smoking, and Substance Involvement Screening Test. And the nice thing about this is it is a web-based interactive tool. So you can print the paper one, you can do it with paper if you don't have access to an iPad or a computer or something to do this with the patient. But if you can do it on the web-based tool, it's really nice in that it starts with, similar to the Audit C, it's 8 questions that evaluate 10 different substance classes. That's your initial screener. And then it goes through and only asks the questions that relate to the substance class that the patient endorses. So if they don't endorse marijuana and cocaine, they don't get any questions about marijuana and cocaine, but they get all the questions for the substances that they endorse having an issue with. So it gives you a really nice level of specificity. It's a range of substances, alcohol and included. It can be completed by the clinician, or it can be completed by the patient, again, online or in a printed version. And here's the link to get to that. So if you haven't used this before, this is a really great screening tool. Couple more screening tools that are used for symptom trackers, because you mentioned earlier that screeners can be used to help make that treatment recommendations to determine level of risk, but they can also be used as symptom trackers. And so the COWS and the CWAR are two that are used routinely in clinical care to determine when somebody is in withdrawal, when somebody would be appropriate to start on a medication, or just kind of rating where they are at any point in time to track those symptoms of either opiate withdrawal or alcohol withdrawal. And then finally, the last screener that we're going to talk about are UDAs or UDMs. And everything that I've shown you thus far is self-report. So we know that sometimes patients don't necessarily want to be as honest on self-report for various reasons. Although the data does suggest that by and large, when you give folks a questionnaire, they tend to answer it honestly. But sometimes that's not the case. And it's always good to have some objective data to support the subjective data that you're collecting, because you're wanting to make the most informed choice that you can in terms of recommending treatment or what you're going to do in that conversation with that patient based on what they're telling you. And so collecting a UDA, both as part of that initial screening process, can tell you a lot about what they've been using, at least recently, and then using it as an ongoing instrument similar to the COWS or the CWAR, other things that we would use as symptom trackers. It can kind of tell you the progress in treatment over time. So this is also a very helpful screening tool to incorporate into the work that you're doing with folks. Now, there are mental health screening instruments that are public domain, and that I would very much encourage people to consider if you're not already using this as part of your routine care. Using things that can get you a brief information about somebody's mental health symptoms that may be interacting with their substance use would be things like the GAD-7, which is generalized anxiety disorder screener. So it gives you some information about if they may have some anxiety symptoms. The PCPTSD is just a 5-question brief screener assessing for if PTSD may be an issue. You wouldn't use it for diagnosis, but it would help you to have an idea of, do I need to assess further, such as giving them the PCL5, which is a much more involved screener, which gives you more information about if somebody may or may not have PTSD. The PHQ-9, of course, is a very helpful instrument for looking at a possible depression. It does have a suicidal question at the end, which could prompt a provider to say, I need to do a more thorough risk assessment to determine is suicidal ideation a potential issue. So these are all things that can be really helpful to provide both at that initial session and then ongoing. The other thing that's really helpful with working with substance use disorder patients is that we don't want to get too focused on just their use. We want to be looking at their quality of their life in general and really getting informed about what are the things that they value. How is their use impacting the things that are truly important to them? And so adding on something like the WHO-QOL or the quality of life instrument, those are instruments that can give you back a lot of really rich data about how they're functioning in the world in general. How are they taking care of themselves or taking care of others? What are the things that they wish that they could do more of that they're not able to do right now because of their symptoms? And in terms of having motivational conversations, that can be really, really helpful. So if you're not using a quality of life instrument of some kind as part of your screening process, that's another one that I'll always recommend you include, because it can just really be helpful with having some of those more motivationally driven conversations. Now that's screening. We said that after screening, if someone's positive, then you would move on to assessments. And most of you are going to be familiar with this process because you do it anyways as part of your intake, right? A good H&P is going to include collecting all of this information, the demographics, their presenting problem, their psychiatric history, medical history, social history, legal history, all of that information, which gives you kind of in a snapshot, a picture of the person that you're working with. The one thing that we don't routinely include, which I want to make a little plug for here, is always including a thorough chart review, because oftentimes there are things in the medical record or requesting the medical record from where they received treatment prior that could save you a lot of time in just knowing that that occurred or that that assessment already took place. And then also getting collateral, getting an ROI for somebody that's currently in their life and reaching out to that person and even just asking them some very brief questions. What did they notice that the patient is struggling with? What from their perspective should be the focus of treatment? That kind of information can be really helpful, especially with our folks that may not be very good historians for various reasons. You know, their memory could be impaired, or they may have some low insight and may just not be able to report accurately what they're struggling with, versus somebody who cares about them may be able to shed some light on that and add some more dimension to that assessment. Now, I've given you a list of both public domain and paid instruments that, if you wanted a structured assessment tool, these could be helpful. So the ASI is a common one that people are usually familiar with. It is free if you want to use the PDF paper version, but if you would like to use the computer scoring version, there is a small fee associated with it. This is a structured interview that a clinician can use to guide gathering all of that information for a comprehensive assessment. The brief symptom inventory is another one that includes some substance use pieces, but gives a lot of information about mental health conditions. So OCD, depression, anxiety, psychoticism, all kinds of things are included in the BSI. The OTI, or what's called Opiate Treatment Index, is not just for patients who have an opiate use disorder. You can use this with any substance. It does ask general questions about duration, frequency, intensity related to substance use in general, but it also collects information about general health, mental health, criminality, and other high-risk behaviors that sometimes we forget to ask, that could really be important to understand in terms of somebody's general risk out there in the community. And then the next list of instruments are really used primarily in research with substance use disorder, but they can be useful if you have a patient who's really struggling in terms of their historical report. So they're just having difficulty giving you the type of information to be able to make an accurate diagnosis, in which case you could pull out one of these, and it's a structured way of really collecting that substance use history and the symptoms associated with it, to get a clear picture of that person's use disorder profile. Okay, so that's all I have here. I will end and see if there's any questions.